forehead is worst in the morning and at times wakes her up from sleep. It is worse when she bends over, okay, or strains. She has also noticed that she gets double vision at times. On examination, you notice that she is obese and has bilateral papilledema. The rest of her exam is normal. You suspect that she has idiopathic intracranial hypertension. Which of the following is not a feature of idiopathic intracranial hypertension? A. Bilateral cranial nerve 6 pulses, cerebrospinal fluid opening pressure of greater than 25 centimeters of water, pulsatile headache relieved by lying flat. Anyone who can help with this one? What do we think? Okay. Mm. Would you want to continue, Doc? Okay. Headache relieved by lying flat. Okay. Is there anyone that has got a different thought process or a different thought on the answers? Anyone? All right. So as our good doc has said, it's not a feature. We want what is not a feature. Now, as you can see, what has been described in this question, uh, we have got a bilateral cranial nerve palsy. Look at this. In the question itself, there is papilledema. There is also, they've actually told us the headache worsens when someone bends. And then there's also double vision. Okay, this is already showing us features of uh, intracranial hypertension. So for intracranial hypertension, the cranial nerves might be affected because they actually originate. Like for example, cranial nerve number 6 is coming from the brain stem, and we define hypertension as a pressure greater than 20 millimeters of mercury or greater than 25 centimeters of water. And then you can as well have tinnitus, this ringing sensation, because you are having the involvement of the cranial nerve number 8. So for this saying headache relieved by lying flat, this headache is going to be worse when someone lies flat and instead of being relieved. Okay. So the best option here is going to be D. Number 22 is saying a 50-year-old man with a history of chronic hypertension presents to the clinic with a 3-month history of intermittent chest tightness. On exam, he is not in respiratory distress and his blood pressure is 190 over 105. That's very high. Which of the following is not an indication for urgent treatment of hypertension? Acute renal failure, stable angina, hypertensive retinopathy, pulmonary edema. So which of these features will not make us to urgently treat hypertension? Anyone? Let's feel free. So when you look at If someone has hypertension, it can lead to retinopathy. There can also be pulmonary edema, and renal failure can occur. Even chest pain can happen, but now this is stable chest pain, like stable angina, meaning that it only comes when someone is at rest, they are just fine, and then it only comes when someone is having this strenuous activity. So that is not an agent treatment for hypertension, the stable angina, because it's only coming when there is strenuous activity. But for these others, acute renal failure, pulmonary edema, hypertensive retinopathy, you want to quickly treat the condition. Number 23 is saying a patient recently diagnosed with lower limb deep vein thrombosis is prescribed factor 10 antagonist for anticoagulation. All the foreign drugs are the factor 10 antagonist except rivaroxaban, dabigatran, apiga, ga, apixaban, fondaparinux. Anyone who can help us with this one? Okay, with the factor 10 antagonists or inhibitors, 10 is X. So if you just see an X in the name, it means that it is a factor 10 inhibitor. Okay, so things like rivaroxaban and then apixaban, fondaparinux, but dabigatran is not a factor 10. Actually, when you look at the way we classify the drugs that act on disorders of bleeding, we have got those blood that will help in clotting and those that help against clotting. So I've got the anti-clotting agents and then the drugs that facilitate clotting. Those that facilitate clotting, you basically replace the clotting factor that is deficient. For example, in hemophilia, you replace the clotting factor that is deficient, even vitamin K in case it's the one deficient, and also antiplasmin drugs. Plasmin is this guy, okay? Plasmin cuts down fibrin. I'm going to mention something about it. Okay, let's mention it before we go to the others. So what happens is that in our body we have got what we call plasminogen. Plasminogen is going to be converted to plasmin by many things. For example, TPA, tissue plasminogen activator, and urokinase, UPA. You also have factor 11A, 12A, all these can activate plasminogen plasmin. Now, plasmin is actually a CZ that will break down fibrin into the fibrin degradation products. And the common one is what we call the D dimers. That is a fibrin degradation product. So, if you see a lot of D dimers in the body, it means that someone had a clotting disorder and then those clots have been broken down. Okay, for example, if someone has pulmonary emboli or deep venous thrombosis, in those conditions you expect to have D damage because there's clotting that is happening inside. All right, but now, so if you want to stop, okay, because remember plasminogen is breaking down fibrin, meaning that it's what promoting bleeding, because fibrin is what stops bleeding. So if you want to promote no bleeding or to work against bleeding, you can give drugs that to be able to inhibit plasminogen. For example, when you give plasminogen activator inhibitors, these two guys will inhibit the plasminogen activators. So meaning that these two guys will actually not be able to stimulate plasminogen. Okay, so meaning that plasminogen will not form plasmin, and then you are not going to have any breaking of the fibrin, including also alpha 1, alpha 2 anti plasmin, and also alpha 2 macroglobulin. These two guys will literally inhibit plasmin, so plasmin can't break down fibrin. So this one will promote clot formation. So alpha 2 plasmin and the alpha 2 microglobulin and also the plasminogen activator inhibitors, those promote clotting. But then tissue plasminogen activator and urokinase, those are going to be promote breaking down of a clot, so they promote bleeding. That is why, for example, streptococcus produces what we call streptokinase, which is basically this same TPA. And so that's why in strep, the infection is going to be generalized. It spreads throughout the body because you are producing, the bacteria itself is producing an enzyme that is promoting no formation of fibrin, because the fibrin is supposed to hold the bacteria at one point, but then this bacteria is not being held at one point, so it's spreading throughout. All right. And then we have got the anticoagulants. But for the anticoagulants, we classify them, those bloods that we use to prevent coagulation, we classify them into anticoagulants, thrombolytics, and antiplatelets. The anticoagulants, we have got things like heparin, and also thrombin inhibitors, and also factor 10A inhibitors, and warfarin. And then for the thrombolytics, here you have already formed a clot, but you are trying to break down a clot, because anticoagulants basically stop the coagulation cascade. But thrombolytics, these ones, you've already formed a clot. You've already formed a clot, but you are breaking down a clot. That's why you have got TPA and streptokinase, which is produced by the bacteria. Okay, these are the ones here, TPA and urokinase, really. Okay, the streptokinase coming from the bacteria. Well, how do these do? By activating plasmin to break down fibrin. And then you have got the antiplatelets. Antiplatelets include drugs like aspirin. You have got the glycoprotein 2 2B3A inhibitor. You have got ADP inhibitors, and then you have got phosphodiesterase uptake inhibitors. So those are the classes of these drugs. And then when you just look at the examples, the direct thrombin inhibitors that are acting as anticoagulants include heparin, and the direct thrombin inhibitor, which is the bigatran. Okay, these ones you see them ending in gatran, the direct thrombin inhibitors. And then we've got factor 10 inhibitors, which includes heparin, including the low molecular heparin, and also the other direct oral anticoagulants, for example, rivaroxaban, apixaban, doxaban. And then you have got those that prevent clotting factor activation, like warfarin. Warfarin, what it just does is that instead of the clotting factors being activated, it will stop the activation of those. Okay. Okay, so that is what is going to be happening. Number 24, and please take note just that warfarin will actually inhibit vitamin K, okay, which is a drug that facilitates clotting. So it means that if you have inhibited what facilitates clotting, it means that no clotting is going to happen. Okay, so 24 is saying 30-year-old female with type 1 diabetes mellitus is admitted to the hospital with DKA. She is started on an insulin infusion and intravenous fluids. Several hours later, her blood glucose levels have decreased, but she becomes increasingly lethargic and develops a severe headache. Repeat laboratory tests show a sodium level of 122, which is low. What is the most likely cause of this new symptom? Remember, this one has got DKA, type 1 diabetes, and then she's on insulin, and then later on, uh, she becomes lethargic and with a severe headache, and then there is a low sodium. So what's the problem here? Hypoglycemia, cerebral edema, hyponatremia due to hyperglycemia, hypokalemia. Anyone to help with this one? What do you think is the problem in this patient? Like, why would someone end up developing uh, becoming lethargic and headache after being treated for DKA? Okay, now we know the definition. DKA is a state of uncontrolled catabolism. It's actually an acute event, uncontrolled catabolism, where there is acute insulin deficiency resulting in, you have got these features that we need to know: hyperglycemia, where I've got a random blood sugar greater than 11 millimoles per liter, osmotic diuresis and dehydration, and also ketonemia greater than 3 millimoles per liter, acidemia with a pH less than 7.3, and then significant ketonuria. So there's ketonemia, which is ketones in blood, 3, and then ketonuria greater than 2 plus. Okay, it's actually the commonest uh, endocrine emergence disorder. We know the different risk factors, but then what is going to happen in this condition is that as you are treating the DKA, remember there is insulin deficiency, isn't it? Okay, there is that insulin deficiency. So what happens if you give someone insulin? Giving this insulin to the person is going to correct that hyperglycemia. And the problem with this is that it's going to cause the shift of fluids. Okay, it's going to cause a shift of the fluids. And what happens is that that shift of fluid, there's a lot of fluid now that has gone into the brain. Okay, there's a lot of fluid that is entered the brain. And guess what happens in that case? When there is a lot of fluid that is going to the brain because of the treatment of the condition, there's going to be that cerebral edema. And it's actually because of this cerebral edema that someone is going to start developing these CNS symptoms that we can see here. And then maybe something that we need to know is that what is the effect of glucose on the levels of hydrogen, not glucose but insulin, on the levels of hydrogen ions or on the pH and also the concentration of potassium in the blood. Anyone that can help with that one? If you give someone insulin, what will happen to the concentration of hydrogen and what happens to potassium? Anyone? Okay. Now we know that. Okay. So we know when you look at the inside of the cell and the outside of the cell, let's say this is the ICF. The P's are more out inside the cell. For example, potassium, phosphate, proteins, those are more inside the cell. But what happens is that when someone has got DKA or hyperglycemia, you are going to have acidosis. So the acidosis is going to, what does it do? The hydrogens are going to go and displace the potassium from out of the cell. So the potassium is going to leave the cell. Okay? It is more in the blood vessels, it's extracellular. But with the correction of the acidosis, the potassium will start going back into the cell. And that is going to lead to hypokalemia. But then the problem is that there's also going to be a movement of uh, water, which leads to this cerebral edema. And that is what causes the neurological symptoms. Okay, just a quick overview again. Please know these features of DKA: hyperglycemia greater than 11 for the random blood sugar, osmotic, someone has got urination, okay, osmotic uh, diuresis. Why? Because of the a lot of sugar in blood. The sugar is also reaching the kidney, and then it will make a lot of water going there. That is leading to the diuresis, and then there also be dehydration because you are actually losing the water from the diarrhea. And then there's ketonemia and ketonuria. Please know the values: ketonemia 3, ketonuria 2 plus at least, and then acidemia is 7.3. Remember the normal is 7.35 to 7.45, but the definition here is not 7.35 but anything less than 7.3. Okay, what causes DKA? Someone has got diabetes type 1, but then if there is any trigger, for example, there is an infection, or maybe the insulin pump failure, psychiatric disorders, previous DKAs. Okay, so those can be stimulators, especially these illnesses. The clinical features are basically the features of diabetes. And really, what happens in DK when you look at the clinical features is that someone has got diabetes. So, what happens there is uh, there is insulin deficiency. Now, normally this insulin is already deficient, we know that. But when there is a trigger, acutely there's going to be this acute insulin deficiency because of that trigger. Okay, even if it is already deficient, but because of this trigger, it becomes acute. And then what happens? You have got this hyperglycemia that will start leading when the urine actually the glucose reaches the kidney, water also be going there. So there will be osmotic diuresis that leads to polyuria. And that polyuria is actually what is going to result in dehydration. And then what the body is trying to do, because the body is interpreting that you don't have glucose in the body, it will start breaking down the fatty acids. And then there will be an increase in the amount of free fatty acids. And then the increase in the production of ketone bodies, because when you're breaking down fatty acids, you go into beta oxidation. What are the fatty acids we're talking about here? The ketone bodies: beta hydroxybutyric acid, acetone, acetoacetate. Those are three. But the acetone itself is actually going to give you a smell. Okay, so the increase of of these ketone bodies is known as ketonemia. They are going to increase in blood. Specifically the ketone body acetone can go to the respiratory system because it's volatile, and then it is going to change the smell. Okay, the acetone odor in people that have got diabetes. And then for the acetoacetate, the beta hydroxybutyric acid, these ones will result in metabolic acidosis. And if they go to the kidney, they are going to result now in ketonemia, the one who described greater than 2 plus. And then the metabolic acidosis, the body trying to compensate, you are going to be breathing out very fast so that you remove excess carbon dioxide. That is respiratory compensation. And so you are going to develop cosmos breathing, this rapid and deep breathing. Okay, and then because of the metabolic acidosis itself, again there will be these acute abdominal pains and vomiting that will develop. And this, because of the abdominal pain, someone is and vomiting, someone will end up again with dehydration. Okay, so that is what happens. So therefore the diagnosis of DKA, you diagnose diabetes, you look at the ketone bodies, and then you also look at the acidosis. Okay, diabetes, ketone bodies, and then acidosis. You can also classify the severity of DKA: mild, moderate, severe. The mild, you can see the pH 7.25 to 7.35. Moderate 7.15 to 7.25. And then the severe, the pH is even much lower, 7.15. Okay, less than 7.15. And then in mild, someone is oriented to time, place, and is oriented basically. And then in moderate, there's the cosmos respiration, and then that is also present in severe, where you can also have depressed respiration. But then you also have the levels of bicarbonate. If the bicarbonate is between 16 to 20, that is mild. 10 to 15, that is moderate. And then if it is less than 10, that is severe. Okay, bicarbonate. The management, because it's a medical emergency, do the ABCs and then admit to ICU. Replace the fluids and treat the electrolyte imbalance by replacing the ions, and then also give insulin. Okay, you want also to restore the acid. Basically, I want to correct all those mistakes. On the acid base balance, you do something. On the hyperglycemia, you do something. On the electrolytes, you do something. On the fluids, you do something. Okay, so the problem is that actually when you are treating DKA, the potassium is going to shift going into the cells, and that leads to profound hypokalemia, and this can cause death if it's not treated. That's a problem with the treatment. And then the cerebral edema is actually going to be present as a complication of treatment, and it will present as headache, irritability, reduced conscious levels of consciousness, and then may complicate therapy. and result from rapid lowering of blood glucose and osmolarity. All right, question 25. A 64-year-old male chronic smoker presents with a history of feeling unwell for the past week. He feels tired, feverish, productive cough with greenish sputum. He ignored this for a couple of days as he often had a smoker's cough. He has a 100-pack-year smoking history and has continued to smoke despite recent increased shortness in breath. What is the most appropriate first-line diagnostic investigation for this gentleman? Sputum culture, spirometry, chest X-ray, C-reactive protein. Okay, let's first start. What do we think is the diagnosis for this patient? Y- Yeah, pulmonary TB. Thank you so much. So, what would be the first investigation or the investigation of choice that we are going to do? Yeah. Thank you so much, Doc. Yeah, for this one, we are going to do a chest X-ray as a first thing. Mhm. So, with these features that are here, it might be, or we've not been told about more of the B symptoms, but it can be TB, it can be a pneumonia. So a chest X-ray is going to quickly give us information to assess maybe if it's a pneumonia or if it is a mass in the lungs. If there's obstruction, a chest X-ray is going to quickly help us. But when we do culture is going to help us in identifying the organism that is causing the problem. Spirometry is going to help us to identify if it's an obstruction. C-reactive protein if there is inflammation. Okay, those are a bit of more specific things that we'll be looking at. But a chest X-ray is going to help us to find out the general problem in our patient. So it would be a good one we can do at the beginning. A 65-year-old man with poorly controlled hypertension and diabetes presents with sudden uh, onset bilateral lower limb weakness that happened 5 days ago. Lie, what's this? Okay, I don't know what that was supposed to be. Lie describes that he felt. Okay, this is supposed to be he, not lie. So he described that he felt a sudden sharp pain in his back and then fell to the ground to leg weakness. On exam of the legs, you note that tone is increased, power is about 3 over 5. He has a hyperflexion and upgoing toes. Okay, we know that sign. He cannot feel pain and temperature on the umbilicus, but vibration and proprioception are perceived. His arms are not affected. He denies any trauma. What is the most likely localization? Hemichord syndrome, anterior chord syndrome, posterior chord syndrome, transverse chord syndrome. Any thought on this one? Let's review the problem in this patient. Okay, hypertension and DM, and then there's bilateral. So let's draw the patient. Okay, there. So for the legs, both of them, there is weakness, bilateral weakness. And then what have we been told? Increased power. Power is increased. Okay. Oh, it's actually tone that is increased, not power. So increase the tone, and then there is hyperplexia, high reflexes. It cannot feel pain and temperature. So not feeling pain and temperature should tell us which tract has been affected. Anyone? Pain and temperature, which tract are we thinking of? The lateral spinothalamic, yeah, or the anterolateral system. And then vibration and proprioception are preserved, meaning that the posterior aspect of the spinal cord is okay because that's the one responsible for proprioception and the vibration. The dorsal column, medial meniscus is fine, is intact. But the front part where you have got spinothalamic or anterolateral system is the one that is having a problem. He denies trauma. So what is the most likely localization? Hemichord. Hemi means half, right? Like half of the spinal cord is injured. And you know that is not true. If it is hemichord, you are going to have features of uh, injury to the dorsal column and also to the anterolateral system because even the posterior aspect is involved. Anterior cord syndrome, okay. So we have got anterior cord and then posterior cord. Obviously, for posterior cord, we can literally remove it because for the posterior cord, we have the injury to the dorsal column, so meaning that proprioception and vibration would not be intact. So the two answers that remain with, we also have transverse cord. Transverse means you have got a spinal cord. At one level of the spinal cord, you just cut like that. Okay. So for us to understand whether our answer is going to be transverse cord or anterior cord, remember for this one we've been told you cannot feel pain and temperature up to the umbilicus, meaning that pain and temperature it can't feel all the way down. Okay, it can't feel, and meaning that it's actually both sides. So as a review, when you look at transverse cord syndrome, it's actually going to be the best in this case because the the features that have been described, like the reflexes, that means that it's an upper motor neuron lesion. There's also Babinski sign where the toes are going upwards. That's upper motor neuron lesion. And then the sensory loss uh, up to the umbilicus, but preserved proprioception, as we've said, it means that there is actually sparing of the dorsal column, but injury to the spinothalamic. And that's actually a feature of the transverse cord syndrome, which involves complete or near complete transection of the spinal cord, affecting the spinothalamic tracts and then sparing of the posterior column. For hemichord, that's the Brown-Sequard syndrome, there's going to be incomplete spinal cord syndrome where there's going to be damage only on one side. So the features will be different. Okay, for the anterior cord, there's going to be damage to the anterior third of the spinal cord. So you would be literally saying the injury, the features of the anterior aspect of the spinal cord where I've got the anterolateral system, things like pain and temperature. So this one, the symptoms will be bilateral motor paralysis and loss of pain and temperature below the injured site. But there's going to be preserved proprioception, vibratory sense, okay, because those are found on the posterior aspect. That is similar to what has also been presented for this question. Okay, but then remember for this question, it's not only this, there are also features of upper motor neuron lesion. And then what else here? Okay, the bilateral motor paralysis is also present in our question. Loss of pain and temperature, but this is below the injury site. Well, same with this question. If let's say the injury was at the level of the umbilicus, it means that even the area down would have basically the same features that we are seeing would be the same things. But then how are we going to explain things, for example, like the upper motor neuron lesion symptoms to now include the features of the anterior spinal cord that has been injured? So that's the transverse spinal cord becomes important. So for the transverse cord syndrome, the damage is the entire spinal cord at a particular level, blocking impulses completely. So here you are going to see bilateral loss of motor function, and then actually for this one, even bowel and the bladder dysfunction is going to happen because at a specific level of the spinal cord, that is the transverse cord syndrome, is all removed. So even the bladder symptom, you gotta remember the bladder symptom, the bladder features, and the spine and the not, but the control of the internal anal sphincter is a reflex that goes to the spinal cord. So there's going to be loss of bowel control and bladder control. So those are going to be the features. But have they mentioned anything like that here? Okay, I can't see any. Okay, let me just take it again. So, controlled hypertension, diabetes with sudden onset bilateral lower limb weakness that happened 5 days ago. Described that he felt a sudden sharp pain in his back, then fell to the ground. On the exam, the legs, you notice that the tone is increased, power is about 3 over 5. He has hyperreflexia and upgoing tone. He cannot feel pain and temperature up to the umbilicus, but vibration, proprioception are preserved. His arms are not affected. It denies any trauma. What is the most likely diagnosis? Okay, so I think the best one we can pick here, because they've not really mentioned anything about bladder and bowel function, which will be also features of the transverse cordis resection. I think the best one we can pick is anterior spine injury. Is there anyone that has a different thought before we move out of this question? They mentioned the bladder symptoms. I think the best we could have gone is the transverse, the bladder or uh, uh, loss of bowel movement. Okay, hope that's fine. We can now go to the next one. A 56-year-old woman presents with upper abdominal pain that she ascribes to stress. She was recently appointed as manager of a large company. She takes an over-the-counter antacid with temporary benefit. She uses no other medications. One night, she awakens with nausea and vomits a large volume of brownish material. Upon hospitalization, she is found to have an active bleeding duodenal ulcer. Which of the following statements are true? The most likely etiology is adenocarcinoma or the duodenum. The etiology of duodenal ulcer is different in women than in men. The likelihood that she harbors Helicobacter pylori is greater than 50%. Organisms consistent with H. pylori are rarely seen in biopsy in patients with duodenal ulcer. How about this one? Any thought from anyone? Any thought? Let, let's feel free, my good doctors, to just open our microphones and then we give our thoughts. No one? Okay. So we've already been told that this patient has duodenal ulcers. So we just want the features of duodenal ulcers. Now we know that for all ulcers, actually in third year, remember one doctor mentioning to say, is it in third year that was in internal medicine rotation? Any condition that you are suspecting PUD, but there is no H. pylori. It actually said is not PUD. It's not peptic ulcers. I remember someone asked, how about if someone has got an ulcer, just any ulcer? Eh, And then they said, whatever that ulcer is, as long as there is no H. pylori, it's not PUD, peptic ulcer disease. But you can think of it. How come it's an ulcer, but why are you saying it's not an ulcer? So, in other words, there's always an association between peptic ulcers with Helicobacter pylori. So, C becomes a very good answer. Okay, A is saying the most likely etiology is adenocarcinoma. That one is not true. Adenocarcinoma is going to be a rare cause of ulcers. Okay, that's a cancer, it's a rare cause. B is saying the etiology is not different between men and women. So H. pylori mm, is not different. The etiology, let me look at it again. So the etiology of duodenal ulcer is different, or is saying it's different. No, that's not true. The etiology is the same. The commonest cause of ulcers it's H. pylori, and actually the use of the NSAIDs. And then these saying organisms uh, consistent with such pylori are rarely seen in biopsy. They're actually going to be seen, isn't it? Are commonly going to be seen. Yeah. So number 28 is saying which of the following hormones are produced by the thyroid gland? Thyroid releasing hormone, thyroid stimulating hormone, calcitonin, parathyroid hormone. Anyone who can help with this one? Okay, thank you so much. Yeah, this is gonna be a calcitonin. Which cells produce calcitonin in the thyroid gland? The parafollicular cells, also known as, they are just known as parafollicular cells. And then which ones are going to produce the thyroid hormone T3 and T4? Sorry, which one will produce T3 and T4? So you basically have those epithelial cells that are lining uh there's that body, what's that? Hmm. The jelly like body, not really body, but the fluid that you find on the middle. How come the name has gone? The name has gone. Where are going to find the thyroglobulin? It's a very simple name, but I don't know why it has gone. So those follicular cells are the ones that will be able to produce that. Okay. 29 is saying a 45-year-old man presents to the clinic for an evaluation of hypertension. He went for a routine medical checkup a week ago and his blood pressure is 160 over 100. Two further readings that week were 156 over 98 and 166 over 96. Which of the following is the most appropriate initial test or examination in a patient with a new diagnosis of hypertension? ECG, echo, fasting blood glucose, urinalysis. So, a new diagnosis of hypertension, what would be the most important investigation? Anyone who can help? Now, we know that hypertension can actually lead to these heart disorders, right? Yeah, it can lead to heart problems. The hypertensive heart disease. For example, it can result in arrhythmias. They can actually literally be heart failure because of hypertension. They can be ventricular hypertrophy. That ventricular hypertrophy is actually on the left side because we're pushing against the resistance. That can actually lead to heart failure. They can be ischemia, ischemic changes. So all these, the ECG can actually be the best to be able to pick up the complications of hypertension. Okay. So number 30, a 40-year-old male with HIV and a CD4 count of 143 initiated on ART at a local clinic 2 weeks ago presented to the ART clinic for a routine review. He has no complaint and examination reveals no abnormalities. What investigation should be ordered? Urine lamp, chest x-ray, serum, cryptococcal antigen test, all of the above. Okay, HIV and the CD4 143. Which one should we do first? Anyone? Now, the only way you'll be able to answer this question properly is after we have understood if someone has got a CD4 of 143, what are the infections that this patient is likely going to develop, okay, as a complication at that level. So when you look at the CD4 count and then the common associated disorders with them, a CD4 count that is greater than 500 cells. Here, mostly you are going to see pneumonia and dermatological conditions like hairy leukoplakia, vaginal candidiasis, Kaposi sarcoma, and then HIV meningitis. Okay, that's for a CD4 count greater than 500. You can have meningitis there, and then these Kaposi sarcoma and the others. For a CD4 count less than 500, here you are going to have the TB. And then you have got things like thrush, Eps zoster, Eps simplex. And then for a CD4 count less than 250, this is where PJP comes in. And then you have got HIV dementia. And then the non-Hodgkin's lymphoma. And then another important one is, another important value is CD4 count less than 100. Here you have got conditions like uh, esophageal candidiasis, cryptococcal. This one can lead to meningitis, of course, cryptococcal meningitis, toxoplasmosis. You see those. And then you're going to have the disseminated Mycobacterium avium complex. And then if it is now less than 50, this is when now you start having these weird conditions, especially the fungal infections comes in when the CD4 count is really less than 50. Pseudomonas, pneumonia, histoplasmosis, aspergillosis. You have got CMV, even the viruses, CMV retinitis, CNS lymphoma. Okay, this now comes in when the CD4 is less than 50. At 100, you have got the crypto and these other things. So this is 143. So it is actually between 100 and 250. The conditions that this patient might be actually likely to be suffering from include things like PJP and everything else that is on top. Things like TB, herpes, everything that is on top. So urine lamp can be helped in that case and checks X-ray. What are we trying to rule out in that case? The same TB, and then serum cryptococcal. I think we can still do the cryptococcal. Here it's showing at a level less than 100, but you can see that is where cryptococcus is. So I think it's important for us to do it here because 143 is not too far from this 100. So someone can develop cryptococcal meningitis. So we can do all of these results. The urine lamp, especially for those who are below 200, important. What's the importance for a urine lamp? This is when we are trying to consider TB. Chest X-ray again, TB. Serum cryptococcal antigen is for the cryptococcal meningitis. But that one, remember the CD4 is essentially if it's less than 100. Okay, but because it's screening, we can We can screen even someone who has got 143 because it's still at risk. Set 1 is saying a 20-year-old female with a long-standing history of type 1 diabetes mellitus presents with nausea, vomiting, and abdominal pain. She has been non-compliant with her medications. On examination, she appears dehydrated and has a fruit odor on her breath. Her blood glucose level is 30 millimoles per liter. The arterial blood gas shows pH 7.25. Which of the following does not occur in the pathophysiology of diabetes ketoacidosis? Reduction in glucagon activity, reduction in insulin activity, increased gluconeogenesis, increased lipolysis. Anyone with a thought on this one? Okay, so it's A, isn't it? So because this is in diabetes, what happens is that for diabetes, uh, insulin is the one that is not working. So since insulin is not working, what will be happening is that glucagon is working more to try to increase the levels of glucose. Okay, so there's actually going to be increase in the activity of glucagon. Right, so that is what happens.